Hi everyone, this is Laura Pegram from NASDAQ. We're going to get started in just some time for folks to log on. Just as a couple housekeeping reminders, all attendees for this webinar will be on mute. You can add in your questions to the question box, and there's also a raise hand box. Either we'll go to the same place and we'll field those throughout the event and have a dedicated time towards the end for some really robust, good discussion. And just so everyone knows, the webinar is going to be recorded and publicly available. So if folks in your network, or if you want to review later at a different time, this will be available, I believe, kind of probably cross-posted among CDC, NASDAQ, and HRC. So I'm going to give it just like 1 or 2 more minutes to get going, and then we'll get going. Okay. All right. Okay, so let's go ahead and get going for the sake of time. Again, everyone is going to be on mute and you can type in questions in the question box or the chat box, and we will answer those towards the end. The webinar is going to be recorded and will be publicly available. So welcome. So today we're here to have a great conversation around syringe services programs and harm reduction programs as being essential services throughout the country, and in light of the pandemic, the COVID-19 epidemic across the country. We have a real range of speakers from the CDC, the Harm Reduction Coalition over here at NASDAQ, and then maybe the most important speakers of all, the ones who are operating programs on the ground and doing the really good hard work of making sure people who use drugs are centered in this response and maintain adequate and comprehensive care as well as possible. So without further ado, I'm going to go ahead and just kick us off. We're going to start off today with Alice Asher from the CDC. Alice, do you want to kick us off?
Sure. Thanks, Laura, and thanks everyone for joining today. Really appreciate it. Syringe services programs are effective community-based prevention programs that can provide a range of services to people who inject drugs, including access to and disposal of sterile syringes and injection equipment, vaccinations, testing for infectious disease such as viral hepatitis and HIV, naloxone distribution and linkage to infectious disease care, and substance use treatment. Syringe services programs prevent infectious diseases and overdose deaths among people who inject drugs and connect them to substance use treatment. These programs not only are critical to ensure the continuity of harm reduction services, but also for SARS-CoV-2 and COVID-19 education, testing, contact tracing, referral to health care, and in the future, vaccination for people who inject drugs. Next slide. Today, I'm going to talk briefly about the effectiveness of syringe services programs and how SARS-CoV-2, the virus that causes COVID-19, affects these programs in the United States. I will review key points in CDC's interim guidance for syringe services programs during COVID-19, including guidance related to COVID-19 transmission prevention and providing harm reduction services during the COVID-19 pandemic. Next slide. Syringe services programs are one of the best tools we have for addressing overdose and infectious disease related to injection drug use and engaging people who inject drugs in meaningful ways that can have a positive health impact. Syringe services programs have the power to cut HIV and hepatitis C transmission in half and to decrease bacterial infections that are caused by unsafe injection practices. A recent study estimates that implementing an SSP in Philadelphia averted over 10,000 HIV infections in the first 10 years of operation and yielded a one-year investment of return of almost $250 million. When people who inject drugs have access to medications for opioid use disorder and comprehensive syringe services programs, transmission of hepatitis C and HIV can be reduced by 74%. Together, these are by far our most effective tools for addressing infectious disease transmission associated with injection drug use. Next slide. For nearly 30 years, research has demonstrated that syringe services programs are safe, effective, and provide critical services. Research suggests that people who inject drugs who interact with a healthcare provider at an SSP or through street outreach are more likely to engage with a primary care provider. New users of SSPs are 5 times as likely to enter treatment for a substance use disorder as those who don't use the program, and 3 times as likely to stop injecting altogether. Moreover, they are more likely to be retained in substance use treatment 12 months later. SSPs do not increase crime and help keep communities safe and clean. Next slide. Unfortunately, despite their critical importance to the health and well-being of people who inject drugs, SSPs were quickly impacted by the COVID-19 pandemic. In a survey of 173 SSPs conducted in April 2020, over 40% of facilities reported a decrease in services, and 1 out of 4 reported closure of 1 or more sites. Of course, this was just a snapshot in time. This survey is ongoing, and future reports will tell us more about longer-term impacts to SSPs. Next slide. A CDC qualitative portion of this survey involved conversations with SSP staff in 5 jurisdictions that were identified as COVID-19 hotspots in April. This part of the survey found that SSPs are experiencing high demand and are adapting to the pandemic. Many SSP programs have changed distribution models. As a result of prioritizing staff and client safety from COVID-19, many programs reported limiting or eliminating screening for infectious disease, which can require close contact, while working to continue to provide sterile injection supplies and naloxone. Most programs are screening clients for signs and symptoms consistent with COVID-19, and some are able to provide SARS-CoV-2 testing. Next slide. There is growing concern about the impact of COVID-19 on people who inject drugs, both in terms of COVID-19 disease and other adverse health outcomes resulting from not having access to syringe services programs. Therefore, CDC recommends syringe services programs be considered essential to public health infrastructure. SSPs ensure that people who inject drugs can access a relatively seamless network of services. These programs can also reduce persistent health disparities and negative health outcomes related to injection drug use. Further, syringe services programs can help to detect COVID-19 cases and prevent the spread of SARS-CoV-2 among people who inject drugs through services related to COVID-19. Next slide. In order to reduce the risk of SARS-CoV-2 transmission, all clients, staff, and volunteers at syringe services programs should wear masks over their face and nose and maintain social distancing. Regular and thorough hand washing with soap and water for at least 20 seconds is important. If soap and water are not readily available, use an alcohol-based hand sanitizer that contains at least 60% alcohol. Staff providing healthcare services should use appropriate personal protective equipment when interacting with clients with suspected or confirmed SARS-CoV-2 infection. When it's a viable alternative, services should be provided outdoors or in an open space. Alternative methods of delivery, such as mail order, may be safer than providing direct services and can help get supplies to clients who are unable to access the SSPs for health or other reasons. Provide education on COVID-19 symptoms to staff and encourage daily self-screening. Programs should ensure that sick leave policies are flexible and non-punitive, and that staff understand these policies. Having a strong staffing plan that accounts for illness or mixed work due to health concerns can lessen the impact to service delivery. Next slide. All clients should be educated on common signs and symptoms and screened for possible COVID-19, and testing should be conducted if at all possible. Syringe services programs, which are built on trusting and open relationships, are well positioned to do contact tracing with clients who test positive for SARS-CoV-2 and should review this process in depth. If SSPs are conducting testing, they should have procedures in place to separate well from ill clients. Otherwise, clients who are suspected to have COVID-19 should be asked to stay away from the facility for at least 10 days since symptoms first appeared, and they have gone at least 24 hours with no fever, without fever-reducing medication, and their other symptoms have improved. Partnerships with local health departments or health organizations may help clients receive COVID-19 related care. Programs should try to provide masks to all clients who need one, and an alcohol-based sanitizer that contains at least 60% alcohol for clients experiencing homelessness or who otherwise may not have regular access to hand washing supplies to take them. Next slide. Maintaining harm reduction services is important amid reports of increasing risk of infectious disease among people who inject drugs, decreased use of emergency rooms, and increases in overdose. Syringe services programs should provide sterile injection supplies, naloxone, and sharps container as much as possible. For staff and client safety, it may be beneficial to make policy changes to allow clients to receive more supplies than usual. This can minimize need to access the program and ensure continuity of harm reduction practices, particularly in the event of an SSP closure or a client unable to go to the facility, for example, if suspected to have SARS-CoV-2 infection. Utilizing peer distribution may also help mitigate disruption in services due to a closure and can help limit the number of people who need to access the program. Next slide. Ensuring care for substance use disorder and associated infectious diseases will provide long-term benefits to individuals and communities. SAMHSA guidance has been adapted during the COVID-19 pandemic to ensure safer delivery of medications for opioid use disorders. Work closely with local treatment providers to support clients' access to these services. Self-testing for HIV is feasible and may be a suitable alternative to other forms of screening. Coordination of healthcare for HIV/AIDS, viral hepatitis, and other conditions during the COVID-19 pandemic is particularly important as openings, closings, and other policies may change frequently. Next slide. This is an extremely challenging time. Resources and technical assistance are available, and I've listed NASDAD and Harm Reduction Coalition's access to COVID-19 support here. Next slide. Thank you for this opportunity to speak to you today. I'm pleased to turn things over to my colleagues and the moderators of our discussion panel, Laura Pegram from NASDAD and Daniel Raymond from the Harm Reduction Coalition. Thank you.
Great, thanks so much, Alice. I'm just sort of serving as a moderator here today, so I will just kind of roll right into a presentation and information from, thoughts from our good colleague Daniel Raymond at the Harm Reduction Coalition. Daniel?
Thank you, Laura. And thank you, Alice. Before we get into our panel, I just want to provide a very brief national perspective building on some of the things that Alice talked about. So I'm just going to go into the next slide. Alice referenced some of this, but there's a number of roles that certain services programs have evolved to take on during COVID-19. In some ways, I think we think about certain services programs either through the lens of distribution of targeted supplies or HIV and hepatitis C prevention. But what we've seen is that these programs work robustly with a broader holistic drug user health orientation. So these are programs that have already learned to take on things like sexually transmitted infections, hepatitis A outbreaks. And so in many ways, they were poised to integrate COVID-19 and SARS-CoV-2 messaging into their work. But what's particularly important here is that our programs are powered by trust. The rapport that they build with people who have many different reasons to feel skeptical or suspicious or alienated from, or just not having access to the typical public health messaging conveyed by government officials, conveyed by health officials, conveyed by the media, conveyed by other traditional messengers. These programs have definitely served to fill a gap here. Along with the roles around prevention, testing, and possibly down the road vaccination that Alice has already mentioned. Next slide, please. So Alice flagged the study about disruptions, adaptations of operations. While the majority of programs have maintained operations, it has not been without some cost. And that I want to just uplift that it's a kind of cultural trait woven into the DNA of harm reduction and certain services programs to be resilient, to be creative. However, it's also been a structural constraint that they've often been overstretched and under-resourced. Whether that's a small county-run health department whose two-person staff have been detailed to COVID-19 response, or grassroots organizations that have a few staff or are volunteer driven and have to navigate different things, the same things that many other people are navigating in terms of elder care, child care responsibilities, their own self-quarantining. And so we've been tested in this moment. And I think that I've been really proud at how our community has stood up and showed up and kept going. But this has been a test, and it has also paralleled disturbing signals that we're seeing increases in overdose fatalities. Latest data from CDC suggests that was a trend that started in 2019 after a brief dip, but has likely been augmented and amplified by the different forms of isolation, both physical but also psychological, that have amplified both the material conditions and diminished the opportunities for prevention and overdose reversal in the context of different disruptions of both social networks and drug supply chains. And for people who use drugs, social networks and connection are a form of resilience as well as resistance to the different forms of structural violence, whether that's around incarceration, homelessness, racism, poverty, that they contend with that shapes their risk environment. I do want to make a note that we've seen increased regulatory flexibility in accessing methadone and buprenorphine that we would like to see move past an emergency phase, but we don't yet have a full picture of whether that has had a substantive impact on both uptake and retention of people on medication for opioid use disorder, which has prevented benefits for both overdose as well as infectious disease. Next slide. So I think as we're going into what's proving to be multiple waves of COVID or the long tail of COVID, that we can see that the lessons from the first few months shape how we can think of our future orientation. And Alice touched on this, that some of the operational barriers and burdens in current state and local policy, whether that's about restrictions in terms of only being able to operate in particular locations, restrictions in the number of supplies or syringes that can be provided in any single encounter, or more broadly, some of the states that have not yet acted to create a policy framework conducive to operating SSPs legally. This is the right time to revisit that. This is the right time to look at either fostering or strengthening partnerships that address structural drivers of risk. Partnerships with homeless services, housing providers, domestic violence, intimate partner violence, reentry parole, alternatives to incarceration, and both drug treatment and the broader healthcare system. This is also going to take a long-term commitment that we cannot leave this population behind, and that we have to name right now as we rethink what we need for broader public health infrastructure, that these programs are essential and they need to be resourced in a way that will allow them to sustain themselves and scale themselves up. Next slide. So I think Alice already flagged, there's some resources on our website, and I'm going to pass it on to our panel and look forward to hearing from them. Thank you.
Great, thank you so much, Daniel, Alice. And I feel like, you know, that set us up really perfectly to kind of get a better span of what's happening on the ground across the country right now. So we are joined by, I'm gonna go West Coast to East Coast, just because I feel like people often go East to West, and you know, that's not always good. So we're joined by Bronze Courtney, who's the Executive Director of the HIV Education and Prevention Project of Alameda County and Casa Segura. Madison Weintraut, who's a Program Manager of the Marion County Public Health Department, the Safe Syringe Access and Support Program. And Mark Jenkins, who's the Executive Director of the Greater Hartford Harm Reduction Coalition in Hartford, Connecticut. So Bronze, let's go ahead and pass over to you, okay?
Hello, everybody. Can you hear me? Hi, as she stated, my name is Bronze, the ED over at HEPPAC, as what we call the HIV Education Prevention Project of Alameda County, also known as Casa Segura. And this is COVID-19 adapting SSPs for our integrated mobile medical model. Just want to send out good vibes and love that everybody is spiritually, physically, and mentally healthy wherever you're at in the world. And yes, these pictures here is one of our great colleagues, Daryl, who is to your left with our Clean Needle Saves Lives in front of our drop-in center. And then to the right is one of our newer vans that was supported by Facebook when our other van got stolen out of our storage that was supposed to be secured. So we'll move along with this. And next slide, please. So just to give you some information about HEPPAC, we are a Black-owned, Black-led harm reduction agency. As stated, we do an integrated service model, which includes medication assistance, treatment, navigation. We have a medical doctor. We do HIV testing. We have hot food, just a whole plethora of items that we do out in the public at our syringe service programs, as well as our drop-in center, which is called Casa Segura, which is the safe house. So just kind of wanted to talk about when we first were like, we're going to shelter in place, you know, people were like freaking out. So I was like, y'all, let's just freak out. Let's have our 5 minutes of, oh crap, we've never experienced this thing called a shelter in place. What does that mean for us? Some staff were like, hey, I am not going to be able to do it. I'm going to need to work from home. I have a compromised immune system. Other staff were like, put me in a hazmat suit. I'm a HEPPAC harm reduction warrior. I'm ready to hit the street. So we just wanted everybody to acknowledge that this is something new that a lot of us have never been through, and just kind of get the oh bleep out, and let's figure out how we need to move forward. So acknowledging that. The next was immediately contacting our board of directors and getting their buy-in and their suggestions on what they felt was going to be best for the agency. Some of the board was like, yo, we don't have all the data. Should we just be shutting this down until we figure it out? And some of the board was like, hey, welcome to public health, right? This is what we signed up for. And, you know, let's try to look at what best practices are. Let's see what's currently going on right now. And like, this is what we signed up for. Let's just do it. So we checked in with staff. We checked in with the board. At this point, there still was not as much guidance as there is now. So what we decided is that we were going to immediately scale back services. What that looked like for us was we were not allowing anybody into our drop-in center, which really sucked because we do a basic needs drop-in center, one of the only in East Oakland where people can take showers, laundry, just get off of the streets, things of that sort. And folks take ownership. That is their space. They're like, what? You're not letting me in? I can't shower. I can't do these things. And so what we did was we did door service, and we had tables in front to adhere to social distancing. So people were still able to get food, hygiene kits, safer smoking supplies, harm reduction supplies, so on and so forth. But they could not come in. They could not use the bathroom. They couldn't use our backyard, couldn't shower, laundry, none of that. So just acknowledging that that really sucked for us, and it sucked for the clients. When the stuff from CDC and state and local guidelines started coming out, it was like things were changing by the day. Wear masks. These are the kind of masks that you can wear. Don't do this, don't do that. Make sure you do this, make sure you do that. So we were just like, it was a daily thing of checking what the best practices were. And so then we started doing brainstorming and then seeing how this relates to how we provide services, seeing that most of HEPAC services is out in the community, out in the streets, in our RVs, in the homeless encampments, on the street corners. So we know that, and someone used this terminology, when the world gets the cold, Black folks and vulnerable populations get the flu. So immediately I hit up our local health department like, yo, we've seen this with every epidemic, pandemic that has come about. It's going to hit the Black community real hard. So what support do you have? Know that I'm about to blow a budget on all kinds of PPE. So I'm letting you know, like right now, if you don't have free PPE from me, then this is what's about to happen. Mind you, this is at the place where PPE and toilet paper and everything was real scarce. So just trying to get basic face masks was like a problem. Folks were like scrounging around trying to find face masks and all these other PPE items. So kind of, you know, doing that and then informing funders what our needs when we talked about like the spending, like, hey, the line item we had for harm reduction supplies, half of it might just be, you know, hand sanitizer, face masks, and like the gowns and things of that sort. So just being able to adapt to that, it was not easy, but in harm reduction, I feel like we're very reactive. We were birthed out of reaction to things happening. So it was like, okay, COVID-19 is here. Now we got to react to this crap. So, you know, welcome to working in harm reduction, you know, for some of the new folks who were unaware. They were like, oh my God, I just started and we're in a friggin' shelter in place. I'm like, well, welcome to HEPAC, East Oakland. This is what we got to do. And then also like informing folks of becoming Zoom experts. I had folks who were scared to touch the computer and scared, like, what is a Zoom? And now they're like Zooming from their iPhones. And so it was an increase in a lot of our staff's development as this whole pandemic was happening. Next slide, please. So taking action, right? So the demand and the request and the stockpiling of PPE. I was unapologetic. I was hitting people up. I wasn't polite about it. Where's our PPE? We need it. And I don't want just the little, you know, lower grade stuff. I want the high grade stuff that I see the nurses who are working on the streets. Like, don't just think you're going to give us the minimal stuff here. I want the good stuff, top of the line for the staff. And then also what we need to give to our participants. Then it was all about social distancing. We are used to like giving daps, hugs to our clients. So it sucked that we had to give like this strong arm, 6 feet, hold on, back up. We're practicing social distancing. What does that even mean? So then, you know, just having those conversations with our participants and acknowledging that this is not easy. We still love you. We can still holler at you. We got to talk a little bit louder through our face mask, but you know, we're right here with you. Shifting schedules, right? All of us were in the office tight. Now it's like we're splitting schedules, staggered hours. So if you came in at 10, it was like, come in, get your outreach bag, hit the street, because we got another crew coming in at 12 noon who needs to do the very same thing. And then we adopted what we call the food truck style, which is basically not getting out of our RV. This was in the earlier part when the pandemic hit, and we were like serving people from the RV. So window 1 was get your demographics, window 2 which was tell me what your order is, and window 3 was where you get your actual products. So we kind of adopted this, what we call taco truck or food truck style services. Like I said before, drop-in center, we started doing door service. And then with our mobile services, we really had to scale back at the encampments. There was still not clarity on how we are supposed to interact at the homeless encampments when the pandemic first came about. So we were just like, you know what, let's just do our fixed syringe exchange sites, which are close to and near a lot of the unhoused homeless encampments. So we were just letting folks know, hey, we're not able to hit up all these encampments, but the exchange is still operating, same amount of time. It looks a little bit different. There's cones out, there's the social distancing, all that stuff is going on. We should start listening to what participants need. Some of our folks literally were not able to shower or clean up at like the Burger Kings and all these other places because everybody shut down. So they were like, I just need a place to wash my hands. And I was like, whoa, it's on that level. So HEPAC was like, let's blow this budget. We're going to buy 5 hand washing stations, 1 for each exchange, 1 at the drop-in center. They're portable. They weigh like 50 pounds. We can, you know, transport them easy on and off the RV. So we got that going. which participants were happy about. And then we had to check with our referrals, like who's doing what capacity are you doing it, who's closed, who's open, like what is the pulse of the people who are collaborators and what are they doing? Because we know that our participants need more services than what HEPAC can provide. Next slide, please. This is us out in these streets. This is actually our new building. We had a Black Lives Matter because we had to board up our building. We're still out there. Mobile harm reduction is still out there doing our thing. And it's not what you do, it's how you do it. And we are still learning every day what our participants need, what our best practices, and we're just going to keep trucking it along. Some of our staff are making supplies at home. A lot of our staff are still out in the streets. We're a little hazmat suited up. And yeah, next slide, please. If you need to contact me or anybody at HEPAC, please feel free to email me. Go to our website. We have updates there. We've just started updating our Instagram because everybody seems to conversate on Instagram now. So hit us up, get on your IG, kind of see what we're doing, what's the pulse of what's going on in Deep East Oakland and Oakland, California with HEPAC. And thank y'all so much for letting me be a part of this panel.
Awesome. Thanks so much, Bronze. That was inspiring and lovely. Just really so good to hear about services and, the adaptations that happen on the fly that we know harm reductionists are, used to and good at, and really just great to hear from you. So look forward to hearing more during the questions. So now we're going to move a little further east and kind of head towards what I would think of as the Midwest over in Indiana, and we're going to pass it off to Madison.
All right, thanks. A little intimidating to follow Bronze. You have quite the response going on, so it's really impressive. Here in Marion County, so Indianapolis, we launched our first legal syringe services program in April of last year, so we were really just getting amped up as the pandemic hit, and it really hurt us a little bit. At the time that we closed, we had a mobile unit, a box truck that traveled to a couple locations in high-risk neighborhoods, as well as a storefront that allowed us to operate 5 days a week. Next slide, please. And then on March 25th, the governor shut down the state for shelter in place, and it was the same thing. It was like, oh my God, what are we doing? Most of the health department had been segued into COVID response long before that, so we didn't really have staff to have any sort of large special response. We stopped all of our operations for just 5 days, actually. So we stopped our mobile unit on March 23rd. And before that, we had really been amping up our syringes and naloxone and harm reduction supplies. We've been packing in extra hand sanitizer and soap to all our harm reduction kits, preparing for what we anticipated to be a shutdown. We then implemented a no contact delivery model for our participants once that shelter in place occurred. We did not want to keep having our mobile unit out and about because of our relationship with law enforcement is already pretty delicate. And with a shelter in place order, we did not want anybody getting pulled over with the idea that they were going to and from the syringe exchange during a shutdown. So instead, our participants just texted an address to a peer support specialist, and that peer support specialist would bring them whatever they needed. We could pick up, use sharps if they had them. If not, that was no problem at all. We doubled our normal syringe distribution and also doubled our naloxone distribution during that time. We also started having weekly phone calls with a lot of other harm reductionists throughout central Indiana. So local grassroots organization, Overdose Lifeline, a local emergency department, and started paying attention to how many overdoses were occurring. And we saw that we had, more than a twofold increase in the number of ambulance runs for overdoses. So to address that, we started putting together naloxone kits, and every day our epidemiology department runs a list of all of the addresses where an ambulance went to respond to an overdose the previous day. And now a peer support specialist will go and drop off naloxone, no pressure, no strings attached. Just the UPS delivery type thing where they have 10 doses of intramuscular naloxone, 1 dose of intranasal naloxone, a resource card that has everything from syringe exchange to fentanyl test strips, naloxone, 211, which is our state's resource phone line where you can get anything from unemployment to insurance navigation, as well as recovery resources, food banks, and the like. We also have a sampling of intranasal and injection harm reduction supplies in those kits, as well as non-perishable food items. So that's going to be continuing for however long it takes for the overdoses to start decreasing. I don't know if it's sustainable for the future indefinitely, but we definitely, during this time when there are limited resources out and about in the community, we want to make sure that people are able to get those. We did reopen our box truck on June 5th, and it's operating a lot like Bronze's, where I hadn't heard it called a food truck delivery model, but I like that. So we have a handicap entrance on our van, and we've been serving people from that. So it's a large open window. That's where they're doing their intake interview, which has been drastically decreased. And then moving on to a second window for the exchange itself. We have had to halt our immunization and testing during this time. A lot of that was we tried to do outdoor point of care testing and found that the weather was just too hot for the tests to really function the way they were supposed to. And rather than give misleading information, we thought we'll just put a pause on that. We already have a hard time getting staff for that component of our exchange, but likely in the next probably month or so, we'll resume that. And we'll also continue to provide free immunizations for our clients. One of our big concerns right now is there are only 2 of us on our team right now. So if one of us gets COVID, then the other one is definitely going to have to quarantine, and our program would be shut down for 2 weeks. So it's been important to make sure that we have some volunteer staff to support us if anything like that should happen. And then we also have been continuing to increase our syringe and naloxone distribution so people have enough supplies to at least make it 2 weeks, where if we had to halt our services, they could get through that. Normally we operate on a hybrid needs-based and 1-to-1 plus model, where the first 4 visits, people get just needs-based negotiation for how many syringes, and then we rotate to the 1-to-1 plus. But right now we're just doing strictly the needs-based to make sure at least 2 weeks worth of syringes and up to a month for people that need it. We've also continued with our delivery services for those that are high risk, particularly our clients living with HIV. We want to make sure that they don't feel the need to come out and visit the syringe exchange if they don't feel comfortable with that. So we're trying to really meet our clients where they're at, what are their particular needs to get those services that they so desire. It's been really heartbreaking, the number of people that have come up and they're ready for their second HPV dose, or it's been 3 months since my last Hep C test. I'm really ready for that. Where can I get it? And we're really hopeful that we'll be able to resume those services shortly. So thank you so much. I did not put my contact information on here, but it's just mweintraut@marionhealth.org. My phone number is 317-221-8332. Anybody has any questions, I'll be here for the discussion, and I'm available afterwards as well. Thanks.
Great, thank you so much, Madison. I feel like, there are a lot of themes that we're picking up on, both from sort of our initial speakers around, sort of modifications in program practice and policies around exchange models and venues. But you also bring up a really, a couple additions of just like some new unique partnerships, thinking about the EMS naloxone drop-offs and also using technology and sort of, mobile services a little bit different. So really just impressive work, and so grateful. And we can make sure that your contact information is in the final slides that are posted. All right, so now we're going to move as far east, well, not as far as east as you can go, but close, over here to Mark Jenkins, who is the Executive Director of the Greater Hartford Harm Reduction Coalition. And yeah, Mark knows a thing or two about new partnerships and partnerships in this time. So Mark, I'm going to pass it over to you.
Okay, thank you. And thanks everyone for sharing before me. Brian's impressive, and I tell you, it's also gratifying. It's that affirmation when you're doing like work and you've never talked about the work that you're doing, and you find you're doing similar things, but also that we can take from each other, because the hand washing station, that got by me, but not for long. All right. So we will see that. Similarly, here, initially when this began to happen, there was what are we going to do? Follow suit. But we knew we could not close our doors. That's just not how we're built, not how we're wired. And so the first thing was to figure out how do we maintain the service level to the people, because our primary source, and although we've done and built the organization on outreach, we have operated a drop-in center here in the city of Hartford for about 2 years now. And the numbers of the individuals that we see have been just extraordinary. And, for the size of the area and the part of town that we're in, we can average days where we see 100 or service 100 individuals. So to go from that to, not allowing anyone in onto the property, also, we went to a one at a time. So we had to back up. And again, similarly, there were no PPEs. There was none of that. We were a little on the lucky side because we had just started gearing up for a bunch of testing. So having a huge amount of hand sanitizer, gloves, and things like that went away, kind of quickly. But we were able to just get in there. I guess I kind of I'm trying to figure out how to word this. I didn't want to go with a PowerPoint because I didn't think with the amount of time allotted it would be necessary. But I see where it is because a lot has been covered. But we have gone from seeing, well over 1,000 people in the course of a month to seeing, to going to a more of a mobile. So we also, like you, Bronze, we have a mobile unit. The city of Hartford, the mayor reached out, or the Department of Health, actually, public health reached out. And when the shelters began closing down, or they were channeling everyone to the central location in response to the social distancing demands that had been placed on them, we in like responded and placed our RV, which I don't know, do we have a picture of it? So, hey, look at there. There's a picture of our RV and also our mobile units. So we placed our RV outside of one of the hotels that housed at times upwards of 200 people. So we were able to also provide a full supply of harm reduction engagements, as well as connection to treatment, because early on it seemed as though connection to treatment for opioid use disorder slumped off, but those for alcohol really took off. So having that treatment on demand model where anyone who walked up to the vehicle, had access, and we also transported. And then the vans went to what we call an ice cream truck style approach, Brian. So like, Mr. Softy, you wave them down, you get an ice cream. Well, with us, you got crack pipes and condoms. As those flags you see on the back of the truck are flying, you can wave them down, and our staff is instructed, pull over. And we, like you, also increased. We brought on more staff actually, and so we were able to rotate and keep the hours and actually increase our hours and service to the population, and the city assisted with this funding. So it made it all quite possible, where now we're able to be on the street for 12 hours a day, and have these vehicles, the vehicles out there. We also, applied directly to the state to become that essential service and have the essential service designation. However, having that essential service designation didn't bring about the same supplies that everyone else got as those essential services, like the hospitals. So these are some of the things that we had to, constantly, when people asked, well, what do you need? We need face masks. We need, it's hard when you get a phone call and they ask you what you need, and you state what you need, and they say, well, we don't have this, we don't have that. Well, what the hell do you have? If you just wanted to call to say hi, you could have did that with the email. We're trying to get work done. And so we were, it was very discouraging, but again, thank, great thanks to a couple of private foundations also that said, use those funds as you see fit. And that's all you had to tell us. So we're stocked to the rafters now with PPE, and we make sure everyone that stops at the van not only gets, masks, gloves, small hand sanitizer, bar soap, but we created literature in English and Spanish to make sure that we could give out also. Know your rights cards, things of that nature. We adapted another program where we're telling people, don't run, call 911, because overdoses are up. People, for some reason, services are down. We've worked locally with other organizations to, have bathrooms, the porta potties installed, because, homeless encampments here, we unfortunately, again, law enforcement were, shutting them down and running many of the staff, underground. And we know, or history has taught us, when you put these individuals underground, it becomes a lot more dangerous. So we still struggle to get a central location where we can make sure we can meet the needs of the people that we look to continue to serve. I think that we covered. I know there's a whole lot more. I'll say, oh, I didn't. The other thing was making sure that we get, our overdose care packages. When we respond also to overdoses in our area, and we, get calls in from those bracelets, we also monitor through a beacon network that we're a part of. We make sure that we get these overdose care packages into the hands of those individuals who survive the overdose, but when they encounter first responders, they lose everything, that all the work that we've done to help keep them safe. Sterile syringes, IDU kits, all those things. So we're grateful that our first responders will allow us to, leave these kits with the individuals, or they'll, give it to them for use at that point of discharge. And we've also partnered with a couple of the EDs here in town. So I'll cut it short, because there's a laundry list of things that I'll continue to remember that we've done. But we continue to look for ways, and thank you for your time.
Yeah, great. Thank you so much, Mark. That is a laundry list, but a really, really important one. I do want to, be respectful. We certainly have a few questions in the chat box, but I'm going to take, I guess, a moderator's privilege and, first off, just appreciate you all. And second off, I've heard so much about these really unique and innovative ways that your programs have been adapting, and you've been adapting to emerging and, responsive to emerging needs. I guess my question for you all is, like, what's the next adaptation? What's the next thing you're hearing from participants? What's the next kind of service that you want to be incorporating to make sure that your folks are getting, you know, what we think of as increasingly comprehensive care and services?
Well, I could say our folks definitely just still need love and support, and recognizing this is hard for all of us, just acknowledging like, yeah, we're still in this, and yeah, we still can't let you into the building, but this is what we can do. Still trying to keep our ear to the street, because we have, now that we're in, I don't know what phase of COVID we would want to call it, but our initial freaking out like was a thing, and now that we've kind of got a grip on how to do things and keep people safe, including the staff and participants, I don't want to say we've lightened up, but we're like being more kind of in the community, getting off the van now. We're still doing food truck style services, but now we're doing it the way we used to do, which is we line up the table, but we're putting a table in front of that table, because they've said, you know, hey, just being out in the open air is prevention for COVID. We're still going to wear masks. We're still handing out all kinds of PPE. We're making sure the hood is flooded with PPE, hand sanitizer, and like just shamelessly asking everybody, I want free PPE. If that isn't enough, we're paying for a little bit. We're still doing groups outside, so unstructured workshops talking about HIV, because you know the epidemic of HIV and Hep C infection didn't stop because COVID showed its face, right? So it's like, hey, if you might need condoms, we know you're not, you know, social distancing, but how are you doing this? Really asking people on their strengths-based approach on how they're staying safe. What do they need? Because it changes by the minute. And then we got some donations from Steph Curry's World Kitchen. So we're getting like donated food, and folks love that, right? Food is always bringing folks in. So just finding anything and everything that could help our folks, because they still can't go into some of the Burger Kings and use the restroom. The city isn't always providing every encampment with the hygiene equity and the porta potties and all that. So just linking with folks like, where's the bathrooms at, and where's this at, and what's going on over here? So just keeping our ear to the street, like finding those community gatekeepers who, you know, it's vital for HEPPAC to know these folks, because it keeps us abreast of what's going on and at the pulse of where people need us.
Well, that's one of the things I'll say for us that, you know, we did, even though it was one at a time, at the brick and mortar site, we did still allow people to come in one at a time, you know, for the bathroom. It was right off the bat, you know, temperature taken, sanitize the hands, mask, and then have at it, you know. And unfortunately, that sound right there was the sound of an overdose taking place in our city. So the work continues there. We just actually started doing face-to-face testing. We did 100 HIV and 100 Hep C tests so far this month. So you know, things are slowly but surely we're able to do a little more also. But the sandwiches is the big piece. Food, you know, we found out just really, you know, people were hungry. People are hungry. And now, you know, we're making sandwiches. We're making 100 sandwiches a day in collaboration with a food pantry, not a food pantry, but a soup kitchen. And we're, you know, and so now we're in the sandwich making business. Who knew?
All right.
We're using this also as an opportunity to re-educate law enforcement on some of the issues that we're having. So the jail here did try to reduce the number of inmates during the outbreak. But unfortunately, you know, possession of a syringe is still a level 6 felony here in Indiana. And what we found was that officers, in spite of the fact that the jail's reducing the number of inmates, a lot of our participants were continuing to get arrested for unlawful possession of a syringe all by itself. And so we've partnered with Leo Beletsky and his team at Northeastern to integrate some SHIELD training with our officers and talking about like why we don't want to, you know, somebody that you arrest has COVID. Now you have to isolate. You've taken them to the jail, the intake officer there, you put them in the jail where the whole jail is going to get exposed to it. And we're just trying to use that as another opportunity to get our law enforcement a little bit more on our side in terms of why unlawful possession of a syringe is not reason to take somebody to jail or arrest them.
Yeah, thanks so much. I mean, for all of these, like turning this emergency into opportunity moments, you know, to really shape services. So we do have a lot of some short questions and some call outs, you know, positive call outs. So slide decks will be available for folks on the call. There is a question. What role do you see substance use treatment providers in either promoting harm reduction services or delivering services? Basically, how do you see them, and have any of you built good, meaningful partnerships with them in light of COVID? And I might just run through a few of them so we can kind of round robin a little bit. We have a question about how much a hand washing station costs. There are a lot of appreciations for the work that you all are doing. This is really a great representation, great spread.
I could say $99 is for the cheapest one. The one you see in the picture, they can go up to like 2,000-3,000, and like something that is so heavy you cannot put it on and off an RV. But we're so many places, I was like, I need something that's not going to break somebody's back and is realistic for us to, you know, tote on and off an RV. We looked on Amazon. There's a lot of different places you can get them. A lot of these vendors who are PPE providers, but get them while they're hot, because now that, you know, COVID's going on and hygiene equity is a problem, like people are eating them up. So we got like 5 or 6 of the $99 ones, and they're like 5 gallon.
Great. And I think another question that we're getting from our rural drop-in center in Maryland is a recognition that shower services, other basic hygiene services are completely cut off in light of the pandemic for a lot of unstably housed folks. So any reflections from the group about responses to that?
I want to talk to Mark like offline on how you're doing your drop-in center, because I'm so OCD when it comes to like hygiene. Like, is a person who comes in and use the bathroom, does that bathroom have to be like sanitized right after? Like, at what level? Because I want to allow our folks back in, but it is not recommended. But like looking at the need of our clients, I'm like, what we got to do? Like, get the bleach, get the face mask, get the hazmat suit, and every time somebody uses the restroom, we just gonna have to go spray it down, let it sit for 5 minutes, and then like, is it at that level? But we can, I guess, talk with the details offline, Mark, because I want to open our doors back up, and our folks need it.
And we can, and thankfully, as I said, no one and my staff has you know, come down with COVID. As a matter of fact, when they tested that entire hotel of shelter, you know, clients, 200 people, not one positive test. So it went back to early on when I was saying I was actually more of a risk. As a matter of fact, one of the shelter execs, a couple of the shelter executive directors, I believe, tested positive. I was more of a risk to the population I served because of the upper circles that I was in of people who traveled versus the people that we serve that don't leave 3-block radiuses. You know, so, you know, while we have to maintain a level of safety, I truly believe a lot of it was out of fear and unknowing. There was more pressure on not knowing what to do. And then it came down to it. You know what I've always been told from my predecessors, and I know Mark will hear this, just do the work. Just do the work, you know, and then we'll deal with the backside. But as long as we make sure we stay safe to the best of our abilities, then that's the best we can do. And as far as the shelters, we just actually last week talked with one of the shelters that still hasn't opened back up, but they are willing to allow participants to come in and use those facilities. So we're going to provide transportation. So we're going to put some signs up by the RV also. And when we're out at some of our mobile stops, if people need showers, we're going to, you know, hightail them over to the shower.
That's great.
I know we just purchased some of those stay 6 feet away signs, wear your social distancing, and then wear your face mask. And then we, for staff, started the touchless thermometer. So we're on that level now. Like when you walk in the building as a staff person, you've got to get your temperature gauge and all that. So we're thinking about how we incorporate that with participants. and only basically allowing like a certain amount of participants in the door, which previously it could be, 10 to 20 people trying to come into the drop-in center. Now it's like top 5. So yeah, I'm definitely gonna hit you up, Mark, on kind of best practices on the side on what y'all doing out there, because okay, those are all right.
Well, yeah, I mean, I know that we are at time and a couple minutes over. There are definitely questions that haven't quite been answered, but I think we connected on many of them, and many of them are sort of specific questions for specific panelists. So as a reminder, this will be recorded, and we'll make sure that contact information is sent out, so that we can all stay together and connected as well as we can, like Harm Reduction Community does. I do want to open up for other panelists, reflections for each other, or Daniel or Alice for any final closing thoughts. Questions?
I just want to thank everybody, and especially our panelists. You guys, this was really fabulous, and the work you are doing is so important. And thank you for your perseverance and creativity. It means a lot just to everybody, and especially your communities. So thank you.
Yeah, I'll echo that. Big fans of all of your work, but also I think these conversations have been so critical for our community. As Laura said, it's our connections that are going to make us stronger and get us through this.
Really, just couldn't agree more. As was mentioned before, there's contact information for Daniel, Alice, and myself if anyone needs connection after this webinar, or about TA needs moving forward. Really so glad to get such a turnout for this, and just appreciate all of you for the work that you're doing. So I think that we can wrap it up. Thanks again, everyone, and we'll have an announcement sent out on the same Drug Use and Health TA at NASDAQ.org email with the recording when it's posted, okay? I hope everyone has a great day, and yeah, keep up the good work.
Laura, could you
Peace
put
out
up
from the West Coast.
could you put up that opening slide, Laura, of what it was, please?
I can do it not gracefully, but yes, I can do it. Sure thing. Okay, there we go.
There it is. Yeah.
Great. All right, thanks everyone. I hope that you have a great day.
All right.